Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
The patient is guided into the rearmost, uppermost position, and the jaw is allowed to drop open and in a hinge type movement. Being that this is a reproducible, not influenced by the teeth at this point, we can use this in transferring cast from the patient to the articulator. We find that the patient can make a hinge movement as we demonstrate here, and the dental articulator can make a hinge movement. And what we would like to do in the transfer of cast from the patient to the articulator is to wind up with the same axis so that the teeth, when they're closed the same on the articulator as they do in the patient's mouth. Now the patient can also be trained or educated to make this terminal hinge movement. The patient can forcefully retrude, or not forcefully retrude, but retrude the mandible in the hinge position and open and close on the hinge. From this diagram, we can see the importance of the terminal hinge position, or terminal hinge movement. This diagram represents the most posterior border limits of the sagittal plane diagram. If we have the patient go through the border movements in the sagittal plane, the most posterior border movements, we would wind up with this drawing. The terminal hinge movement represents this part of our diagram where the patient is opening and closing on the terminal hinge axis. Once a patient exceeds the limits of this terminal hinge axis, the jaw will not only rotate, but it'll translate, and it'll give us this portion of our diagram. For this demonstration, we are concerned with this terminal hinge movement, which extends in some people as much as 3/4 of an inch to an inch. The patient can open and close on the terminal hinge movement. And this is the movement that a patient can make around the terminal hinge axis, which is located within the head of the condyle. This terminal hinge movement can be stopped anywhere along this arc or this rotation area. The most superior limits of this is when the teeth come into contact at this position, and this we have termed centric relation. Centric relation is the position where the teeth contact on a closure along the hinge movement. So if we want to locate centric relation in the patient's head, we would have the patient opening and closing along this terminal hinge movement, and then we would bring the teeth, when we felt we had this terminal hinge position, we would bring the teeth into contact, and this would give us our centric relation position, or centric relation contact. This is the tooth contact, or stopping of the hinge at the level of the teeth. If we had no teeth, the closure would just keep going on an arc up until it hit some areas, such as the gum pads in a complete denture patient. Centric relation is the tooth contact position with the condyles in the most superior and retruded position. If we bring the teeth into contact at that position and have the patient squeeze, the patient will slide generally into centric occlusion. The contact generally at centric relation is on inclines, so if the patient tends to close in centric relation, squeezes, they slide into centric occlusion, which is a maximum interdigitation of the teeth. So we have a slide in centric into centric occlusion. This terminal hinge movement can be used in transferring a set of study casts from the patient to the articulator, provided we locate or determine this terminal hinge movement. If the teeth come into contact, as we see at the centric relation position, we would get a slide, or the mandible would be deflected away from this hinge closure. So if we wanted to take a centric relation registration, we would have to take it with the teeth out of contact, somewhere along in this position here, before the teeth came into contact, so that they would not influence the position of this centric relation registration. So there we would come along and stop the closure with a wax registration, and this we would term a centric relation registration. Here we would have the patient closing on the hinge. We would place the wax in between the teeth and stop the closure then at this position. With this idea that we could transfer this wax registration, or the centric relation registration, over to the articulator, and if we had the same arc or the same axis of closure on the articulator as we had on the patient, we could take out this wax registration and close the teeth into centric relation on the articulator. So our problem becomes then one of taking a centric relation registration along this terminal hinge movement, and then having the axis for the wax registration from the patient the same on the articulator as it was on the patient, so that we can take the registration out and close the cast into centric relation on the articulator. One convenient means of using the hinge axis is to use what we call the arbitrary hinge axis. This is an axis point that's been averaged among a number of patients. The one that we use here at the school is to measure from the most posterior part of the ear to the corner of the eye, and we come out 13 millimeters from that point. And then, because the stylus is on the facebow are quite large, we crosshatch this point to give us a mark that is sufficiently large enough for placement of the stylus of the facebow. So this is what we term an arbitrary axis. This should get us fairly close to the terminal hinge axis for our transfer. The exact terminal hinge axis can be located kinematically by using the patient's opening and closing terminal hinge movements. As you see here, we have attached to the teeth that will move with the teeth a stylus that has a contact in the vicinity of the condyle, so that as the patient opens and closes, we can see that the stylus rotates, or in this case, it arcs. So what we would want to do now is to adjust the position of that stylus, which is arcing, until it reaches a position to where it rotates. When we find this position where the stylus just completely rotates, this would be the hinge axis position. To aid us in locating the hinge axis, we will put a surface between the skin and the stylus to give us a contrasting surface. This surface consists of a series of dots which helps us to locate this rotation position fairly rapidly. So what we would do is have the patient open and close on this hinge position and observe the way the arcing is occurring. As you see here, the arcing is occurring superiorly and down. So we'd want to go towards the center of the circle until that point merely rotates. So just hold it there. We'd move the stylus down and backwards to a new dot, and then we'd open and close again. Open a little bit. until we decrease the arcing until the stylus is merely rotating. Hold it there. This is the terminal hinge axis. This is the exact terminal hinge axis of the patient. As the patient opens and closes on the hinge, the point stays still. Now, if we compare this with what we had on the arbitrary axis, we can see whether how close the arbitrary axis is. So let's move the flag away and see where the point came in relationship to the arbitrary hinge axis. Open and close, please. Now you can see the difference between the hinge axis, true hinge axis point, and the arbitrary axis point. In this case, we are down and back from the arbitrary axis. And later on in the demonstration of the effect of the hinge axis, we'll see what this effect this would have on the closure on the articulator. The facebow transfer utilizes the terminal hinge axis to transfer the maxillary cast to the articulator so that it's in the same relationship to the condylar axis on the articulator as it was to the condylar axis on the patient's head. So we center the styluses, or the styli, over the hinge axis point, and we transfer this point from the patient to the articulator. Open, please. And what we're doing in reality is transferring the axis, its relationship of the axis, to the maxillary cast as we mount this on the articulator, so that they are oriented the same on the articulator to the axis as they are in the patient's head. The only other thing that we would need to transfer the cast to the articulator would be a centric registration that we can use to mount the mandibular cast in relationship to the maxillary cast. Now, the only position where these two casts would agree without the teeth in contact would be along the terminal hinge movement. So we would use a wax centric registration. Put the wax in the mouth while it is soft, and we'd have the patient close up and down on this terminal hinge movement, and we would stop the closure with the wax somewhere along that hinge movement. And if we have the correct terminal hinge axis, we should be able to mount the lower cast on the articulator using this centric relation registration to take the centric relation registration out, open please, and then close the teeth on into centric relation and have the same centric relation contact in the mouth as we have on the articulator, or on the articulator the same as we have in the mouth. The facebow is used to orient the maxillary cast in relationship to the terminal hinge axis. We would have the facebow attached to the articulator, centered over the axis of the articulator, and we have our maxillary cast in our bite fork registration, so that this cast is the same distance from the axis on the articulator as it was in the head. We now need to then mount the maxillary cast to the upper member of the articulator. After we've mounted the cast on the articulator, the teeth, these teeth should be the same distance from the axis on the articulator as they are in the patient's head. If they are, then we would be able to close or to mount the lower cast on the articulator in relationship to the maxillary cast, which is in relationship to the hinge axis. The centric relation registration is used to mount the lower cast in relationship to the maxillary cast that is mounted on the articulator in relationship to the hinge axis. The teeth are separated, and we must take the centric relation registration from between the teeth and close the teeth down into contact, and we would hope we'd have the same centric contact. If we refer back to our drawing again, this is our terminal hinge movement. We have recorded our centric relation registration at a higher level or an open with the teeth apart along this closure. And we would hope that we can take the centric registration from between the teeth and have the teeth close into contact, into centric relation, the same on the articulator as they would do in the mouth. So we would want to duplicate this arc on the articulator. So that as we take the centric relation registration from between the teeth and we close the teeth down into contact, we would have the same first contact on the cast as we have in the mouth. If we look at a schematic diagram of what we've just shown here, we can see the effect of our centric registration and also the effect of the hinge axis in our closure. If we have here our centric relation registration between the teeth and we have the correct hinge axis, we should be able to take the centric registration from between the teeth and have the teeth close down into their normal contact relationship, or the same way as they would be in the mouth if this were the articulator. You can see that the teeth are in good contact relationship. However, let's suppose now that the centric relation registration, we've mounted the cast on the articulator with the centric relation registration, and instead of having the correct hinge axis, we have erred, and we have the hinge axis that is higher or above the true hinge axis as we have here, and this is what we had on the patient. So now, if we remove the centric registration and we close the teeth into contact, we would find an error in the way the teeth come together. We would see that we would have a contact in the posterior area and an open area in the front part of the mouth. And the opposite would occur if we erred below the true hinge axis. We'd have a contact first in the front part of the mouth and an open contact in the posterior part of the mouth. Okay, let's take the centric relation registration again, and we have it mounted on the articulator, the lower cast mounted to the upper cast. And this time we have erred, and we have a hinge axis, or we have an arbitrary axis that is behind or posterior to our true hinge axis. Now this time, when we take the centric registration from between the teeth and we bring the teeth into contact, we see that we hit on these inclines rather than having the teeth come into an ideal contact relationship. So that if we err in the location or we use the wrong axis on the articulator, the teeth will not close into contact the same way as they do in the mouth. So the use or error in locating the axis can cause an error in the contacts between the teeth when we go to the mouth. So what we've tried to do is to show that the centric relation position is a stable position. Centric relation is a contact position along the hinge closure or the terminal hinge movement. We take a bite with the teeth, a centric relation registration with the teeth apart, and expect to mount the casts on the articulator and take the centric registration from between the teeth, remove the centric registration, and have the teeth close into the same contact relation on the articulator as we had in the mouth.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.